Hello and welcome. Today in this section, my colleagues and I will be discussing the prevalence and impact of agitation in Alzheimer's dementia. I'm Dr. George Grossberg. I'm a geriatric psychiatrist at St. Louis University School of Medicine, St. Louis, Missouri, in the United States. To discuss this important topic, I'm extremely happy to be joined by my friend and colleague, Dr. Ali Atri, who is a cognitive neurologist at Banner Sun Health Research Institute, also in the U.S. So welcome, Ali.
Thank you, George. Good to be here.
Nice to be with you. And Dr. Bonnie Berman, who's a former care partner for her mother, who was living with dementia, I believe, of the Alzheimer's type, and was also president of the Ohio Council for Cognitive Health. Again, welcome, Bonnie. It's great to have you.
Thank you for having me, George.
All right. So we're going to be talking about this broad topic, recognizing agitation and recognizing that it's a very common kind of neuropsychiatric symptom in Alzheimer's dementia. And we're going to talk about the impact, not just on the patient, but also on care partners like Bonnie. And, Bonnie, I know that you were a care partner for quite some time for your mom who suffered from Alzheimer's dementia, and can, in a firsthand kind of fashion, talk about the impact of agitation on you as a care partner. But before we do that, I think it's important for all of us to recognize just how common agitation is against a background of Alzheimer's dementia. Now, depending on studies that we look at, Ali, I know you've done a lot of work in this area as well, maybe up to 80% of individuals sometime during the course of the disease may suffer from what I've called the spectrum of agitated behaviors, everything from mild agitation or irritability to even overtly aggressive behavior. I wonder if you could maybe elaborate a bit on the prevalence and severity and just kind of the notion of how common this is and when we see agitation against a background of Alzheimer's dementia.
Yeah, thanks, George. It's a very distressing problem. As you mentioned, I'm a cognitive neurologist. I believe that there's different pillars: cognition, function, behavior, and how things are affecting your environment. And of those, I really do think behavior is the most important. You can support the others, but if you have agitation, aggression, irritability, it becomes very difficult to provide that support. And as you mentioned, it really is a spectrum. So oftentimes early on, it's not as noticeable. Maybe it comes out as some irritability or some verbal aggression. But over time, it increases. So in the mild cognitive impairment stages, of this spectrum, studies showed up to 60% or more individuals may have some aspects of an agitation spectrum, and as the clinical condition progresses along with the disease in the brain, this increases. So really towards the moderate and moderate to severe stages, this number goes up to 80% or more. And it's the different domains that are also impacted. I know we can talk about those. It could come out physically. It could come out physically aggressively. It could come out as physically non-aggressively. It could be verbal, both aggressive and non-aggressive. And it could be manifest in motor activities. And understanding that early so that, you can mitigate these things and put in stop gaps and educate the family members, et cetera, is very, very important.
Yeah, so that's a great overview. And I guess one of the things our audience also wants to keep in mind is the impact of agitation, both on our healthcare system, with accelerated kind of disease progression, often leading to more emergency room visits, more doctor visits, more medications being tried, often at great cost, increased risk of ending up in a long-term care environment. But we also want to keep in mind not just the impact on the patient and on the healthcare system, but also the impact on the care partner. And Bonnie, I wonder if you might make some comments about kind of the impact of behaviors, particularly agitated behaviors, their impact on you as a previous care partner and having taken care of your mom with Alzheimer's dementia.
So, George, thank you for asking about that. And I want to answer it from two perspectives. When Ali talked about behaviors, we also have to talk about the behavior of the care partner and that which the care partner may or may not be doing that is either escalating or could prevent the agitation. So our toolbox is pretty big in that regard. As far as the impact on the care partner, I'm 70 years old. I've lived a really great life. If there's one thing I could go back and do, it would be to change my behavior because of what I did to get my mother more agitated. And so I see it both ways, and my life changed dramatically. And dementia and Alzheimer's, specifically Alzheimer's dementia, they don't just impact the individual, they impact everyone who is a care partner. And I'd also like to add that care partner is not only the person who is caring for the person. We're talking about neighbors, we're talking about friends. We all have a role in helping somebody that is living with Alzheimer's have the best life possible and reduce their agitation.
Yeah, those are some wonderful insights. And I guess also we want to keep in mind as you talk, Bonnie, about care partners, a couple of points. One is you being a daughter-in-law, not uncommon for the daughter or even the daughter-in-law, and at least in our culture, for women to be the primary care partner. We also want to focus on the professional care partners, whether it's nurses or nurses' aides and others that work in the long-term care environment, that it's very, very stressful for them to take care of dementia patients, particularly with agitated behaviors. It's one of the leading causes of burnout, one of the leading causes of turnover in the long-term care environment. So it really, really takes its toll. Now, I want to kind of focus also on, Ali, as we talk about all of us as professionals that kind of diagnose and try to manage agitation, how you kind of see agitated behaviors presenting in your practice, and what are your kind of targets for intervention?
So thank you, George. Let me riff a little bit on what Bonnie said and what you're saying, and then I'll get to that. The impact is absolutely huge. It affects outcomes. There's psychic pain in the patient. People end up in nursing homes and facilities quicker and have worse outcomes because of this. And because of the agitated behaviors, you can't provide the care that the patient needs, including medical care. So it turns out that if you can't give people their medications in the right way, et cetera, their medical conditions then decompensate and they end up in the hospital, and then you have the spiral of difficulties. But as far as the presentations are, as you mentioned, a spectrum. So you can have everything from physical behaviors that early on can be non-aggressive. As early on as having pacing, wandering, hoarding, refusing medications, tapping, humming. And again, those are not things that care partners recognize necessarily. They may be disturbing, but they don't necessarily recognize that this is part of the spectrum. When it gets to verbal behaviors, they could be non-aggressive. They could be things like repetitive speech. Funny noises. But then verbally, they can become aggressive. So swearing, cursing, yelling, screaming, changes in energy, volatility, panicking, and episodes of crying suddenly. So this volatility. And then, of course, I think the physically aggressive behaviors, those are the things that suddenly become a crisis. And that's what we want to really also avoid, which is, when people are being pushed, hit, punched, throwing things around. You can see this whole spectrum. and incredibly distressing.
Yeah, thank you for sharing that. And again, kind of a reminder to all of us. And I know, Bonnie, you don't need any reminders because you lived through this with your mother-in-law, but reminder to all of us that even though families do an outstanding job in caring for their loved one with Alzheimer's dementia or dementias in general, it's often these problem behaviors that cause them to finally throw the towel in and really say, I just can't do it anymore. I need to be thinking about a memory care unit or about a long-term care facility. Any final thoughts, Bonnie?
Well, I would add to that is why the whole practice of person-centered care for people living with Alzheimer's is so very important, because we need both care partners in more of a care community, and then family members and loved ones need to understand what matters most to that individual, what are they capable of doing, and to do what we can, all of us together, to ensure that we are creating the best life possible and minimizing the agitation where we can.
That's a perfect way for us to end our segment. Thank you very much. Thank you, Ali. Thank you, Bonnie. Look forward to seeing you and working with you in the future.
Thank you.
Thank you.
Hello and welcome. Today in this section, my colleagues and I will be discussing how to recognize and diagnose agitation associated with Alzheimer's disease dementia. I'm Dr. George Grossberg. I'm a geriatric psychiatrist at St. Louis University School of Medicine, St. Louis, Missouri, here in the USF. And to discuss this important topic, I'm extremely happy to be joined by my friend and colleague, Dr. Ali Atri, who is a cognitive neurologist at Banner Sun Health Research Institute, also in the U.S. Welcome, Ali.
Thanks, George.
And we have Miss Susan Scanlon, who I've also had the pleasure of working with on a number of occasions. She's a true expert, a gerontologic nurse practitioner, and a founder of Dementia Connection. Welcome, Susan.
Thank you, George. Thank you.
We're also joined by Dr. Bonnie Berman. Bonnie is a very special person. She's going to bring a different perspective as a former care partner for her mother-in-law, who is living with dementia of the Alzheimer's type. She's also president of the Ohio Council for Cognitive Health. So welcome to all of you.
Thank you, George.
All right, great to have you. So in this segment, as I mentioned, we're going to talk about the early behavioral symptoms of agitation and Alzheimer's dementia, and also focus on kind of criteria for diagnosis. And one of the things that we know is that it's difficult to diagnose agitation, whether in the office setting or even in the long-term care environment at times. It's a kind of a complex situation. Often care partners may not use the term agitation. They may not even share behavioral concerns with the primary clinician. So I'm wondering, maybe, Susan, if you could kind of start us off and talk about kind of different presentations that you've kind of seen and about the difficulties of making this diagnosis.
Sure. My background has been largely long-term care and also home community. The initial symptoms are often very vague and kind of what we'd say prodromal. They may start off as restlessness, irritability, short-tempered, and often, healthcare providers may not see that as agitation of Alzheimer's disease. We also have issues of family members too. As George had mentioned, a lot of times people don't even connect any of these, early symptoms with Alzheimer's disease. They may just think, oh, that's just my loved one, being cranky. Yeah, I'm sure he's tired of being at home, thought he was being belligerent. And they don't also often use the terminology that we use as far as, the exact terms of agitation of dementia. They might say things like, oh, they're having a meltdown, they're frantic. So we're seeing both the care partner and the person with the symptoms, responding to these very early changes. But they're often subtle and usually not recognized.
Well, thank you for that. So, of course, we encourage, the family, the care partners, and literally every visit with the healthcare provider to talk about any behavior change, anything that's different from the way the person usually is. Now, once we do recognize that agitation may be a problem or maybe in the picture, very, very important, and Ali, maybe you can talk about the importance of a thorough differential diagnosis so that we shouldn't just automatically assume that the agitated behavior is coming from the underlying Alzheimer's dementia.
That's correct, George. I think, one of the major things that we have is the International Psychogeriatric Association consensus diagnosis, which involves, a patient who has a cognitive disorder, MCI, or dementia syndrome, that they're exhibiting one of these spectrum behaviors, excessive motor activity or verbal aggression or physical aggression that's been going on for, a couple of weeks. And it's a dramatic change from their usual behavior. And it's then affecting other domains, such as, causing emotional distress, interfering with interpersonal relationships, social functioning, engagement in ADLs. They're stressful and severe. And the point here is that it's not something that you can really attribute to a medical condition or another psychiatric condition. So when you mentioned the differential is really important. So you think about, are they not sleeping well? Could this be an issue? Is there pain going on? Is there constipation? Is there another medical illness? So in women, oftentimes in later stages, difficulty with wiping can cause UTIs. Could there be a pneumonia or a brewing? And some of these things don't show their symptoms, other than the patient becoming sort of irritable, agitated. Is there a electrolyte issue? Are they dehydrated? High sugar, low sugar? Medications, are there new medications that have been put on board? For example, some that they're withdrawing from, for example, are there anticholinergic medications? Is there too much use of alcohol, for example? Are they forgetting? And then thinking about the environment, environmental triggers, and all the other things that are less under the control of the patient themselves and may have changed. Everything from the not right environment for the patient, too hot, too cold, too stimulating, etc.
Yeah, so that's very helpful. And I guess just to remind all of us that though agitation is extremely common, particularly with disease progression and Alzheimer's dementia, there are many, many other potential triggers. And this is a vulnerable population, and we need to be thinking about those and trying to address those as well. So just your thoughts, Bonnie, do you have any reactions at this point in time from your perspective as having been a care partner for your mother-in-law?
I actually do, George. I found the conversation very enlightening because what Ali was talking about was how the multidisciplinary team needs to be detectives. And I have a Sherlock Holmes hat here, and I put it on all the time when I say, we've got to figure out what's going on. The multidisciplinary team can only be really good detectives if they have all the information. And so involving the care partner in the early stages as part of the care team becomes so very important because the information you want often is not going to be shared. And the first reason it's not going to be shared is the stigma. That we don't want people to know that grandpa is doing this or what's happening. But the second and the really important one to me is care partners often think, why are they doing this to me? Why are they trying to get back at me? And they don't realize that this is not about them. And so we're actually dealing with family relationships here. And so it's really important for the team to involve the care partner to get all of this information to be able to act and react appropriately.
I think that's very, very helpful. Just to add to that, Bonnie, one of the things I've found with families is they're often reluctant to bring behavioral issues up because often the patient's there. So in our setting, we see the patient and the family in the office together. So they may, in fact, approach me before the visit or sometime thereafter, but usually before, asking for a couple of minutes privately so they can talk about these behaviors and not talk about them in front of the patient, as then maybe they'll get them even more agitated, or it's embarrassing, or they're kind of reluctant to do that. And I think that's very appropriate. I do want to get your insights, Susan, also in this area, and particularly the concept of the multidisciplinary team and utilizing the more specific kind of IPA criteria. Do you have any thoughts about that?
Yes, it's great because we can use the IPA criteria to guide us. As George and I have developed a decision tree, and this is available through Gerontological Society of America, through GSA, on geron.org. And what we did was we kind of looked at that criteria, and we listened to the family first. And from there, we, it's good to try to define, as Ali just explained, is it delirium? Is it dementia? Is it depression? And we do actually, the whole team looks and assesses, and it's so important in a team setting, like in a nursing home or an assisted living or a hospital even, for us to get that information, as Bonnie said, gather it from multiple sources. And even in my rounds in long-term care, I was highly dependent on certified nursing assistants being with the residents all the time. Is the patient able to participate in recreation therapy? What information does the social worker get from the family as far as, what's the history? Often we get not full charts when in long-term care settings or in home settings with primary care providers. So basically, we're using that criteria, and then we're going to assess, and we have specific tools: nurse practitioners, PAs, medical directors, primary care physicians. And if those patients are fortunate to have access to wonderful experts like George and Ali, getting them in for that full workup. So we then try to say, let's try some non-pharmacological interventions. And the whole staff and family members are very involved with that. We recommend things like, we'll talk about that again a little further down. We have interventions we can do, and we see if they work. We use assessment tools. The clinicians can use the neuropsych inventory. Cohen-Mansfield inventory has a lot of symptoms that both Ali and George have discussed. So we see, do they respond to our intervention, maybe a non-pharmacologic intervention? If they did, great. If not, we reevaluate again with those tools. And, and then we take management from there.
Thank you, Susan, for those insights. I want to thank all of our guests for a great segment, and I look forward to working with you in the future. Thank you all.
Thanks, George. Thanks, Steve.
Thank you.
Hello and welcome. Today in this section, my colleagues and I will be discussing how the multidisciplinary team can help manage patients with Alzheimer's dementia with their agitated behaviors. I'm Dr. George Grossberg. I'm a geriatric psychiatrist at St. Louis University School of Medicine in St. Louis, Missouri, in the U.S. I have some wonderful guests with me today to discuss this important topic. I'm delighted to be joined by my friend and colleague, Dr. Ali Atri, who is a cognitive neurologist at Banner Sun Health Research Institute, also in the U.S., and Ms. Susan Scanlon, who's a gerontologic nurse practitioner with a lot of experience in this area and a founder of Dementia Connection. So welcome to both of you. Nice to have you with us.
Thank you, George.
So I'd like to kind of start things off by talking about how we can utilize the IPA framework for treatment planning in clinical practice. A couple of things that I've taken away from the IPA definition of agitation and the framework, and I think my guests know about this very well, is the importance of making sure that what we define as agitated behaviors are impactful, that they're really impacting quality of life for the patient and or the family, the care partners, or the professional care partners if they're in the hospital or the long-term care environment. The other take-home point for me is really the importance of persistence of symptoms. The symptoms should also be representing a change from previous behavior. And then very, very importantly, I think, again, as my panelists know very well, to make sure that we're ruling out other potential triggers for agitated behavior, to not in a knee-jerk or automatically kind of assume that these behaviors are coming from Alzheimer's dementia, but to make sure we've ruled out other potential causes. Once we've looked at this agitated behavior and we determine it's part of the Alzheimer's disease spectrum, then of course the first guideline that we have, and again the IPA, all the organizations stress this, is to think about non-pharmacologic and psychosocial care type approaches. And I wonder if maybe, Susan, you could kind of start us off by sharing with us some of the approaches that you found to be helpful.
Absolutely, George. This is so important because, first of all, we have the issue that often families do not understand that we can do something about these behaviors as described in the IPA criteria. We have both research. There's a lot of good research now on non-pharmacologic interventions, as well as psychosocial interventions. So often families and also healthcare providers kind of throw up their hands and say, hey, this is an irreversible illness. It's going to get worse. There is nothing we can do. And unfortunately, a lot of care partners in the community get that message. But what we do know is the multidisciplinary team, whether it's in an outpatient clinic or inpatient long-term care, we can share that there is hope, to manage this, because it's a huge, huge impact. It affects everything the caregiver does. Very often they survive on very little sleep, stress, and depression themselves. Caregivers are often suffering from clinical depression and anxiety because of this. So what we want to do as the team is educate everyone on what's out there. As far as psychosocial things, we can empower families, number one, about communication, because that's one of the most frustrating things. Very often, their loved one will say something or act out one of these behaviors, and the care partner will personalize it. So first of all, we have to teach them how to deal with that, how to respond to that so they're not aggravating, how to sometimes agree with what they're saying as opposed to opposing it and getting them more agitated. So communication, number one. Also the same for long-term care settings and assisted living. They have to know that this is not normal behavior. This isn't Harry's usual self. There is something we can do about this, and we need to empower our multidisciplinary team. Non-pharmacologic things, what works? There's been some great studies on music therapy to calm agitated behaviors. One of them looked specifically at interactive music, where there's a live music participating. That's not realistic for all the time. Another option is music playlists based on that person's type of music. So that's another option. Massage, as far as hand massage, is very good with lemon balm and lavender. Reminiscence therapy, I used to use a lot of validation therapy, in which you engage the person where they're at, exploring the behavior they're describing. What is it you're seeing? And, tell me about, when did this start happening? And then you're entering their world. So important. There's all kinds of, you see things like computers and robots and a different type of interventions. But massage, pet therapy has shown up too. As far as responding to the agitation, we have to look at the environment. Make sure the person at home or in the nursing home, assisted living, is in a calm environment. We want to avoid triggering them either with not optimal communication. Be sure they're comfortable as far as temperature and lighting and noise. Not overstimulated with television programs or the news, for example. We want to simplify their tasks, make it easy for them. And like I talked about, there's many different types of psychosocial interventions. So we want to do those first. Now, if the person is a danger to themselves or others, or a serious safety issue. I've had patients trying to escape for their home, for example. You're not going to try a non-pharmacologic intervention in a serious situation. And Ali will talk about that as far as medications that we can use when non-pharmacological interventions don't work.
Thank you, Susan. You kind of introduced our next section, and I do want to ask Dr. Atri, Ali, to maybe discuss. So in scenarios where, as you mentioned, Susan, where we either don't have the luxury of time for the environmental or the non-pharmacologic approaches to work because it's an urgent situation, or where those approaches have failed and we have ongoing issues, the good news is we now have pharmacotherapeutic interventions that are looking promising. And I wonder, Ali, if you could maybe quickly kind of give us an overview of those.
Yeah, thanks, George. I completely agree with you and Susan that really the first approach, it needs to be a proactive approach of increasing knowledge for the family about communication, about issues that may come up, to understand, what is in the control of the patient care partners, and to kind of mitigate, and also to think about whether if this is a sudden change, could this be medical? Could this be because they're constipated, not sleeping, in pain? Could this be a UTI? Could this be actually new medicines that have been put on, or are they withdrawing from medicines or alcohol? And also, could this be a mood disorder? So, to be proactive about those things, and then to recognize the science, whether it's excessive motor activity, whether it's verbal behavior that's becoming more aggressive, whether it's physical behaviors that are becoming more aggressive, hopefully not to get to the point where, the pot boils over in many cases. So you mentioned what are our options? Well, in Europe, we know that risperidone does have a short-term indication, and really in situations where there is severe and refractory issues that are impacting patient safety. And we know the data about that. There's for groups, explanatory trials have suggested that there's small to medium effect sizes for those. The issue is that there's the side effects that come along with those medications. In the U.S., there's a black box warning, and we actually have not had a new medication approved until recently, which is specifically approved for agitation and Alzheimer's dementia. And one of the major issues, I would say, is that there's this confounding of calmness with sedation. So many of the medicines that have been tried, over the years, and the bar is not low, the bar is high for drug approval. So the studies have shown for a group on average, the benefits have not outweighed the risks, including many of the antipsychotics, anti-epileptics. We have SSRIs, for example, that are used, benzodiazepines that are used, and a mixture of these things are used, but again, off-label. More recently, brexpiprazole was approved in the U.S., and this was based on a decade of research and a number of trials, finally pivotal trials, that indicated that titrating up to over a few weeks up to a 2 milligram dose as being potentially the therapeutic dose, with 3 milligrams being also possible. However, if you look at the response curves for the average patient, this is not a drug that people responded within hours to a day or two. This is something that to anticipate. and on top of best practices. And one of the things that the major side effects of the drugs that are used off-label include, as I mentioned, sedation, but things like extrapyramidal. So people become stiff. They end up becoming very sedated. They aspirate, they fall. So gait issues, cognitive suppression. And one of the things that did not really show up in the brexpiprazole trials was a substantial signal for sedation that, for example, affected falls, for example, or cognitive suppression.
It looks like,
now,
I was going to say, Ali, so it looks like we now have a first FDA-approved drug for agitation and Alzheimer's dementia. And I think, as you very well know, we have a number of promising agents in the pipeline, nothing that's extremely close. I do notice that just in the past week, the announcement came out that deuterated dextromethorphan-quinidine was a negative study, a large placebo-controlled trial looking at the same indication. So this is not an easy area to develop safe and effective compounds in, but I think we are making further progress. So we are running out of time, so I want to thank both of my panelists, Susan and Ali. Thank you all very much for very stimulating discussion, and I look forward to working with you in the future. Thank you.
Thank you, George. Thank you.
Hello and welcome. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America. And I'm joined today by my friend and colleague, Dr. Bonnie Berman. Bonnie is a former care partner for her mom, who was living with dementia, and she's the president of the Ohio Council for Cognitive Health. And today we're going to discuss the impact and burden of agitation in Alzheimer's dementia. Thanks so much for joining me, Bonnie.
Thank you for having me, Jen.
It's a delight to talk with you and learn from your experiences. Bonnie, I want to start with just asking, what was the impact of agitation in Alzheimer's dementia on your mom? What kind of behaviors did you see, and how did that affect her and her quality of life?
Well, Jen, that's such a good question, and I think I'm going to answer it a little differently than you would expect. And that is, the most important impact of agitation was, I truly believe in retrospect, that she didn't feel loved. Because her agitation was a way to express her pain or what she was going through. And when the rest of us did not respond appropriately or to help her, I sense this, that she had a sense of, don't you people care about me anymore? And that was the most tragic part of the agitation, believe it or not.
Bonnie, you shared with me once a story about when your mom didn't recognize you and how troubled she was, but how troubled you were and how you tried to convince her that you were Bonnie. Tell us a little about that experience for you both.
Well, I can't speak for her, but I can tell you, and I've never told anyone this before, that I ended up in therapy because of it. That it was so incredibly traumatic that I did not know how to respond when she didn't recognize me. And so I made it worse. And that's actually why I have dedicated the rest of my career to making sure that people understood that they have a role to play in agitation and other symptoms that come along with dementia. I believe, and I still believe, so maybe the therapy wasn't successful, that I was the problem. But I do think that there's so much that care partners can do, and I wasn't doing them. And my guidance now to people is to help them understand. For example, did it matter that she didn't know who I was? If she knew I brought her joy? Who did it matter to? It mattered to me, but it wasn't about me. It was about her. And so it's changing that frame to what really matters that is so very important.
So what matters most? But what I want to go back to, Bonnie, in your answer are two other questions that I got as a result of that answer. And the first was, you said your mom had different behaviors that were part of that agitation? What were some of those behaviors?
Well, interesting, Jen, they aren't the behaviors that folks often think about. People think about, I think, the aggressive behavior. She did not have aggressive behaviors, but she had a sense of restlessness, such as pacing, repeating the same motions over and over again. And what I saw on her face was that these symptoms were a way to express her distress. And everyone expresses distress in a very different way.
So the theme I'm hearing there is behaviors as a form of communication and communicating need.
Well, and when you are communicating need, Jen, we as care partners, and you know, I define care partners as very, very broadly. Anybody can be a care partner, whether you just see someone in a grocery store or not, that when you see them trying to communicate, it becomes our responsibility to say, what are they trying to communicate? What is this pain? And what perhaps did I do or could I have done differently to either prevent this or de-escalate it?
So that brings me to the other question I thought about when I heard your answer there, and that was, how did you learn those strategies that did work, that helped her to de-escalate? Was it really reflection on previous situations? Tell us kind of the strategies you used and then how those impacted you and her.
I think the strategies are all lumped into one phrase, which is it's person-centered. It's knowing who the person is, and the only way care partners, both formal care partners and informal care partners, such as families, know how to respond is if the person has the diagnosis as early as possible. Because with an early diagnosis, we're able to understand what matters most to that person and to be able to think about it. And oftentimes with what matters most, people think about the big things like end-of-life decisions. But that's not what I'm referencing here. I'm referencing that if my mother was going to go outside, please, please make sure she's wearing her rain bonnet. She even slept in that rain bonnet to make sure her hair would be fine the next day. And so one of the key times of agitation for her was when she was going to go outside, but they didn't give her her hair bonnet. I know that sounds silly, but the agitation started with a segment of agitation started with the hair bonnet incident.
So getting to know not only what makes life worth living for that person, but what's their usual routine, what's important to them, what's their normal time to get up, how they go outside, whether they like I always use the example of, there's a question of, do you like pets? Well, I love my cats and dogs, but I'm not a fan of the birds. So please don't bring the visiting birds to see me if I'm in your care home. So all about learning what's important to them.
Well, and so, Jen, I want to add to that it's what's important to them, but it's also our knowing how to make sure we have built upon their strengths. So that if someone was going to, for example, make sure my mother was wearing the hair bonnet, why not let her put it on? Isn't that just, she feels some sense of control? And so it's a matter of knowing the person well and what means something to them.
Very, very good. How did you learn those strategies? Who was it? A care team? Was it other care partners in your life? How did you learn the strategies you used?
I think one of the things that I have learned over time is that if we flatten the hierarchy, we can all learn so much. Meaning, in long-term care or care for people with dementia, it is the people who are closest who really know what's going on, and we need to listen to them. And so what I learned to do the most is not from books, it was from my mother's direct care workers and the people who really understood her. I'll give you I think a wonderful example is that oftentimes in long-term care, we have great turnover over the stress of bathing because it really is a very difficult situation. But what her formal care partner knew was that my mother had always wanted to lose that last 5 pounds. And regardless of what a surveyor might have thought if they had walked in, she would say to my mother, "Miriam, it looks like you've lost weight. Let's put you on the scale." And of course, women who are listening know we'll even take our earrings off to lose some of that weight. And so it was very easy to get her clothes off because they knew her, and it stopped the agitation. And it was the nurse's aide or the direct care worker was so proud to be able to share that, but it only worked for my mother. It wasn't a matter of something that you would do for everybody. And that's the message here. And that is, you want to empower people to say, well, if this worked for Miriam, maybe that works for Jane.
Right. I think that's a great message to close on: person-centered care and what matters most. Thanks for joining me, Bonnie.
Thank you for having me, Jen.
My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America. And I am delighted to be joined by my friend and colleague, Dr. Bonnie Berman. Bonnie's a former care partner for her mother, who was living with dementia, and she's the president of the Ohio Council for Cognitive Health. And today we're going to discuss the multidisciplinary team's role in recognizing and diagnosing agitation associated with Alzheimer's disease. Bonnie, let's start with talking about your mom's experiences with agitation associated with Alzheimer's disease. What symptoms did she have, and how did they impact her life?
Well, Jen, the symptoms changed actually as her dementia worsened. And so I'll have to just let you know what she started with and where we kind of got. I think that the earliest symptoms really were her restlessness, her pacing, and her inability to have any kind of joy whatsoever. And I think that the restlessness came from what she wasn't able to do, and it was from our inability to understand her and what was important. I'll give you a example in that my mother used to collect a lot of things, which is my nice way of saying she was a hoarder. And when she went into independent living, the apartments are very small and there's nothing you can really take. And so every day she would take the napkin, the cloth napkin from dinner, and she would hide it in a cabinet. When I finally saw that she had 147 napkins, I realized that she was trying to express that need to be able to physically count something and have something and fold something. But since I didn't understand that and I didn't want anyone to know what she was doing or how she was agitated, that I actually took all of those napkins from her. I stole what was important to her and took it home to Columbus, Ohio with me. And I made the agitation so much worse because those napkins were really important to her because they were helping her deal with the restlessness and the inability to actually live her life.
So, Bonnie, when I hear you say you didn't want anyone to know, I think you bring up one of the greatest challenges in diagnosing agitation in Alzheimer's dementia. And that is that families don't know how to talk about it. There's some guilt or shame so tell us about what challenges really exist to diagnosing this for you and what you've seen in your professional career since with caring for people.
I think one of the most difficult parts of diagnosing and managing agitation is the fact that the family and other care partners really don't want anyone to know about these symptoms. One is that there's a stigma involved. Secondly, they feel like it's an absolute failure. How could my mother be like this? This is not the mother I knew. And the third is the physicalness of it that people are really scared to say, my mother has this particular behavior. And in part, that is because we do not do a good job of helping people understand the symptoms of dementia. And many people think the symptoms are purely about memory. And it is the behavior change and the personality change that we need to help people understand. If people understood that, then the care partner, meaning the family member or whoever is providing the care, would be an integral part of the multidisciplinary team. And that's what's most important to me, is how we define that multidisciplinary team. I mean, I want a t-shirt that says, I'm part of this. I matter and I want to be heard, but I only want to be heard if I feel respected and I know that what I say is really going to have an impact on that which the rest of the team does.
I always love the picture of a multidisciplinary team with the individual in the center and everyone else circled around. That's such an important visual, I think, for the team to always remember, and that care partner is one of those spokes right along with all the professionals, for sure.
Absolutely.
You mentioned this kind of where you started and where you progressed, where you went, where your mom went in her disease. So we know that behaviors and agitation change over time. So tell us a little bit about the changes in your mom's behavior over time, and then kind of what you've in your professional career and supporting others and their families, what kinds of behaviors have you seen that also change over time for people? So just some insights on that.
Jen, that's a great question. On a personal level, what changed was what started with her, I believe, frustration about what we were and weren't doing, that she was not heard, that she was not understood. So I am not a clinician, so I can't say what the biologic or the disease-related issues were, but I can say that the more we did not do what we should do, the worse her symptoms got. And I'm going to give you an example, and it's the concept of environmental press. And that what we learned and what made a very big difference was if we could figure out what she was capable of and making sure that we ensured that the environment was at that level, then she would have a much better day. When the environment was asking her to do more than she was capable of, that's when the agitation would start again. When, however, we did too much for her, then that's not good either, because then you're not living the best life possible. So the concept of environmental press, which is going to change daily, is the skill that I like people to know and learn. And I was taught, again, from a direct care worker. I also want to tell you what I learned from my daughter, because you can learn from any place. My mother, they had finally gotten her to the point, despite the agitation, that she would go down to play bingo. I didn't know this. And she was winning. I don't know what winning meant, but she was collecting all these nickels. And she would just play with the nickels and line them up all day, that restless behavior. I was so upset about this change in behavior because I thought the agitation was that she was stealing the nurses' aides' money, that somehow she got somewhere and she was taking the money that they used for the vending machines. And so I took that money, which increased her agitation. And 3 different times in the visit, I did that, in 3 different visits, excuse me. My daughter comes and says, "Oh, Grandma, you're collecting nickels. I have some too. Here, have mine," which brought incredible joy. And so it's a matter of knowing what is causing this behavior and the agitation and the nickels. If I have to pay for something now and they're going to give me a nickel back, I give it back. I don't want to see a nickel.
Bonnie, your stories are always so meaningful. What an insightful story about the perspective of the nickels. I love it. So tell me about the experiences. What a really great multidisciplinary team experience looked like and what a one that really wasn't so great. Tell me, contrast those experiences for me, because I'm sure you had both.
My favorite experience of all time was when my mother was incredibly agitated at lunch, and they weren't sure why. And my mother had not spoken. Her dementia had gotten very bad. And all of a sudden, she came to life. And she said to the direct care workers, "Can I go too?" And what they didn't know is that she was listening to the conversation. It turns out that they were talking about going to Wendy's for lunch. That would, every time I came before my mother got to this level, we would go to Wendy's for lunch. And so that sparked something. And they said to her, "What would you get?" And she said, she hadn't spoken in months. She said, "I would get a chicken sandwich." Despite the fact that it was a very bad idea to take her out, they took her out, knowing that I would want that to happen as her healthcare power of attorney, etc. Even though she could have potentially choked on some of that, they did it because the team understood a couple of things. One, when I told that story ultimately to the medical director, he said, "They did what?" They knew that it was worth it to do it, whether without the approval. And I think that is absolutely fantastic when the team feels empowered. And it turns out that what they did, just so you hear the end of the story, they went through the drive-through, thank goodness. And when she came back, they actually put me on what was then a speakerphone. And it was almost a play-by-play. And she's dipping the French fry in the ketchup now. And it was so exciting. And the truth of the matter is, I didn't know if that was the last time I would be with my mother. But that was okay, because they brought her such joy. And it was all the multidisciplinary team. And it turned out it was just a marvelous thing. And from a staff retention standpoint, everybody else heard about it, and the staff thought, "This is such a great idea." And they would come and say, "Miriam, how was the chicken sandwich?" And the joy they brought to the rest of the staff was extraordinary. So I want to end on that positive note of the team can do amazing things when they understand what's important to somebody, and that when someone flattens the hierarchy and gives them the opportunity to make decisions.
That's a great way to end, Bonnie. Empowering the staff, listening to what matters most to the person, and circling around that person as a multidisciplinary team to ensure their quality of life. What you described there was a magic moment for your mom, that she had joy, and it's all about empowering people to live their best life and have that joy. Thanks so much, Bonnie. It's always great to talk with you.
Thank you for having me, Jen.